Welcome. If you're getting ready for your NHA/CPT phlebotomy exam, you are in exactly the right place. In this explainer, we're going to dive into some of the trickiest procedures and quality checks you'll face, and we'll break them down into simple, memorable steps.
So let's kick things off with a question that really gets to the core of precision in phlebotomy. As we go through the next few slides, I want you just to keep this question in the back of your mind. By the end, you won't just know the answer, you'll understand why it's so incredibly critical for your patients.
So here's our game plan for today. We're going to start with the specifics of venous blood gas tests, then we'll pull back to see the bigger picture with the rules for point-of-care quality. From there, we'll see how those rules apply to coagulation and arterial blood gas tests, and we'll wrap it all up with the core safety principles that are the foundation for everything you do. All right, let's jump right into our first topic, venous blood gas, or VBG. This is a common and really powerful test, but the rules around collecting and handling it are incredibly strict. You absolutely have to know these inside and out for your exam. So what exactly is a VBG? Well, think of it as a vital snapshot of a patient's acid-base balance, but without all the risks that come with an arterial puncture. Now, it can't replace an arterial blood gas, or ABG, for checking oxygen levels, but it is an essential tool for monitoring conditions like DKA or sepsis. And here are the steps that are absolutely non-negotiable. Every single time, you have to use a heparinized container, and hey, remember that question about air bubbles? They have to be pushed out immediately. After that, the clock is ticking. You've got just 30 minutes to get it analyzed, unless your facility policy says it's okay to put it on ice.
And this right here shows you what happens if you don't follow those rules. If you delay the analysis without putting the sample on ice, the living cells in the blood just keep doing their thing, producing more carbon dioxide and acid. This doesn't just tweak the results a little bit, it creates a totally false clinical picture that could lead to the wrong treatment.
Now, this is really interesting. Take a look at how closely the venous and arterial ranges line up for pH and PCO2. See the pH? 7.32 to 7.43 for venous and 7.35 to 7.45 for arterial. They're incredibly close, and that correlation is exactly why a VBG can be such a useful and reliable substitute for an ABG when you're focused on acid-base status. So, for your exam, you need to know this boundary like the back of your hand. A VBG is perfect for monitoring ventilation and acid-base balance. But if the question is about how well the patient is oxygenating, then an arterial blood gas is mandatory. It's the gold standard, and a VBG is just not an acceptable substitute in that situation. You know, the principles we just talked about for the VBG actually fit into a much bigger framework, and that's point-of-care testing, or POCT. These are the quality rules that guarantee those quick results we get right at the bedside are every bit as trustworthy as the ones from the main lab. Okay, pay close attention here because this is a huge topic for your exam. You have to know exactly when to run these external liquid quality controls. I know, most devices have their own internal checks, but those aren't enough. Anytime you open a new box of strips, or a new person uses the device, or you get a result that just doesn't feel right, you have to stop and run a full quality check. I really love this slide because it summarizes the entire quality system in one spot. It's not just about running controls. It's about making sure the specimen itself is perfect. No clots, no air bubbles. It's about proper disinfection. And it's about your safety. All of these pieces have to work together to create a reliable and safe testing environment. So we have these universal quality rules. Now let's see how they work in a really high-stakes area, point-of-care coagulation testing. In this field, a fast result can be life-saving, but only if it's 100% accurate. This table is fantastic because it illustrates the core concept you have to grasp. You must match the right test to the right anticoagulant therapy. You wouldn't use a PT/INR to monitor high-dose heparin, and you wouldn't use an ACT to monitor a patient's daily warfarin dose. You have to know which test goes with which drug. And here is a key distinction for your exam. Do not confuse these two. The activated clotting time, or ACT, is for high-dose heparin used during procedures. The PT/INR is for monitoring the oral anticoagulant warfarin. You need to memorize this pairing. All right, let's look at another critical area where speed and accuracy are everything: arterial blood gases and electrolytes. In an ER or an ICU, these results can drive life or death decisions about a patient's breathing and their treatment. Look familiar? Just like with a VBG, anaerobic handling is non-negotiable. Air contamination will alter the pH, the PCO2, and especially the PO2. You also have to gently mix the sample to prevent clots, and critically, you must always document the amount of oxygen the patient is receiving. Without that context, the result is incredibly difficult to interpret correctly.
Now, what's really fascinating here are the pitfalls. A simple collection error can create a life-threatening but completely false result. Look at potassium. Hemolysis, which is just the breaking of red blood cells, releases potassium, which can make the level look dangerously high. Even something as simple as the patient pumping their fist can falsely elevate it.
Here's a quick and easy memory aid to keep things straight. When you see K+ for potassium, think cardiac rhythm. When you see Na+ for sodium, think water balance. Connecting that electrolyte to its main job will help you a ton on the exam and in your practice.
Okay, let's pull everything we've talked about together. In this final section, we're going to build a simple framework for safety and compliance that will help you master this material not just for the exam, but for your entire career.
Think of these 5 points as the absolute, non-negotiable foundation of safe practice. These are not just some rules from OSHA or the CDC. They are the bedrock habits that protect you, and more importantly, they protect your patients from harm and infection. These have to become second nature.
So think about it. In a busy clinic or hospital, with all the pressure for rapid results, for getting to that next patient, which of these crucial safety steps do you think gets rushed or even skipped the most? And the answer is contact time. It is not enough to just give a device a quick wipe with a disinfectant. That disinfectant needs to stay wet on the surface for the full required time, whether that's 30 seconds or 2 minutes, to actually kill the dangerous pathogens. A quick wipe down just doesn't do the job.
This single sentence is your key takeaway for this entire explainer. It's not about performing just one step correctly. True quality comes from weaving all of these pieces together: specimen integrity, proper device use, and safety compliance every single time with every single patient. So we'll end with this question for you to take with you. The knowledge we've covered today isn't just about passing a test. It's about earning the trust that patients place in you. It's about making precision and safety the absolute foundation of your practice so you can provide the best possible care for every single person you interact with.